Good morning. I'd like to thank everyone for joining us today, and I would also like to thank you for your patience as we held on a few minutes to get started so that we could get the majority of our registrants on. My name is Johns. I'm the Learning and Development Coordinator for the Division of Developmental Disabilities, and I'll be your host for today's webinar on monitoring psychotropic medication. A few housekeeping items. I know some of you have asked about being the only participants on today. We keep the attendee list hidden. It kind of keeps it cleaner on our side, and so it may look like you're the only one on there, but you're not. Second piece, if you have questions regarding technical issues such as sound or something that I can try to help you with today, I will. If you'll put those in the chat box, I'll respond to those there. If you have questions regarding content, we ask that you put those in the Q&A box. We'll be fielding some questions as we go along and as time allows. There will also be the polling feature being used today, so there are a handful of polling questions that you'll be asked to participate in. And from time to time, our presenter will be asking questions that you can respond to in the Q&A box, so there will be the opportunity where we're looking for some feedback. So I believe our housekeeping items today. So I am going to turn this over to Melantha Witherspoon, who I'm going to let her tell a little more about herself and her credentialing. I also want to let you know that I have Dr. Terry Rogers in the studio with us today, who is our Chief Behavior Analyst for the Division of Developmental Disabilities. So all of you, Melantha.
Good morning. Thank you for joining. As I said, my name is Melantha Witherspoon. I am the Area Behavior Analyst of the Eastern Region. I started working in the HAB Center setting where I got lots of experience with working with two wonderful psychiatrists. I'm a licensed behavior analyst with some experience with professional counseling. And so I started with my presentation.
I'm Dr. Terry Rogers, and by way of introduction, I just wanted to say we have a wide variety of individuals on the phone today in different roles, and that's wonderful. A lot of this presentation is geared towards evaluating and monitoring the effects of medications, and so for perhaps nurses or behavior analysts or those folks who would be doing that. Not to say it won't be useful for everyone, because it's good to know what's supposed to be happening. We plan having several follow-up presentations around the topic, and one of the things we'll be asking towards the end is what kinds of additional information would be helpful to you all. So it may be that you're perhaps a foster parent and this seems a little technical. Hopefully you can glean some useful information out of this presentation and think about what else you would need to know. And so without further ado, Melantha is going to get started.
Thank you. I also would like all the participants to know that after this presentation, you will receive an email that has lots of resources in it as well. All right, medication. All of this presentation is to make sure that everyone understands what psychotropic medications are and the purposes of it for our contracted behavioral therapists, to make sure that they are assessing the use of psychotropic medications during their assessment process. I want everyone to understand side effects that are associated with the medication we discussed today and how they can contribute to behavioral issues. I want our contracted behavior providers to also understand what the expectations are when they provide services to people who have an open episode of care with the division, and for everyone to understand the best practice model for psychotropic medication use. Our behavioral providers, licensed behavioral analysts, do not prescribe medications, make decisions about medication management, as well as recommendations to parents, caregivers, or other professionals. So just to be on psychotropic medications, they were introduced in the 1940s and 50s, lithium and other antipsychotics. There was a noted change in behavior when the medication was introduced. Medication is primarily used to treat mental illness and behavioral problems. What's away from this is psychotropic medication has been around for as long as ABA, and we into consideration that with this medication, it has different effects on people. We just don't know a lot about it. So that's one of the reasons why this presentation will advocate for really good understanding of the side effects, collecting data, and having lots of discussion around its effects, because it's pretty young, the use of psychotropic medication. So there are psychotropic medications, antipsychotics, anti-anxiety medications, mood stabilizers, antidepressants, and stimulants and non-stimulants. The most used psychotropics for the populations that are served by the Division of Developmental Disabilities are antipsychotics, anti-anxiety medicines, mood stabilizers, antidepressants, and sedatives. So with psychotropic medications, there are any medications. Sorry. So here again. Yep.
Go ahead.
So this is actually a question that we had loaded. The polling question that you see does match what you have on the screen. We actually tossed in a couple extra ones. So the one that you see right now is really, we're just trying to generate some feedback to make sure that we capture some good data. So I'm going to let you answer this one, close it, and then I'll go ahead and open the polling question that matches Melantha's question.
We want to know what current roles are, if they do anything with medication.
Okay.
So while with that, I'm going to take back just a little bit what I said. I am going to ask you to answer just two more questions before we get to Melissa's actual question. And the last one that I'll derail you on before getting back to our presentation. My apologies for not rolling those out to you initially. With our hurried start, our delayed start, I was anxious to get us rolling.
Okay, the correct answer is D, all of the above. We talk about the various categories of psychotropic medication and the types of antipsychotics, atypical and typical, and the most commonly ones used with our populations is Abilify, Gion, Risperdal, Seroquel, and Zyprexa. I have had a discussion with a psychiatrist who works with folks who are diagnosed, as well as folks who have developmental disabilities, who was kind enough to go over the ranges and the specifics. And I want you to take away from this slide is to look at the possible side effects so that you're assessing if you are working with a person who is prescribed one of these not experiencing the side effects associated with them.
Sometimes find is that the side effects are considered more behavioral problems, and so we start medicating for side effects, and people end up on more and more medications trying to account for the side effects of another medication. So we have somebody who's on Hal and is having trouble getting up and getting going in the morning, and so they go on another medication to help with that. Or we might have somebody who is appear to have dry mouth and wanting to drink a lot, and then we start controlling their fluid when really it's a side effect of the medication. So we always want to consider, could the symptom or the behavior we're trying to address, could that be something that's aggravated or really a product of a medication?
Very well. And these some of the symptoms that are being or taking the antipsychotics. So there are positive symptoms that is it to the person, like hallucinations, delusions, and then there are negative symptoms in which the person loses something, like their motivation to be involved in meaningful activities. They may have a flat back. And then symptoms where people are struggling to follow their daily routine or remember things, as associated with mood. Then we have anti-anxiety medications, which should be prescribed for short-term periods because they have they have an addicting property to it, and you can sometimes see these used well when people are going on clinic visits, such as the dentist or the OBYN. The symptoms that are addressed when people are experiencing issues with anxiety are panic and fear. They see sleeping or concentrating. They may also experience some physical symptoms such as shortness of breath or sweat, and muscle tension as well.
That I wanted to note around anxiety medications or anti-anxiety medications is that we see an awful lot of people who are on anti-anxiety medication for years, and that's problematic. So you're not the physician prescribing it. What you can do is ask the physician, could it be a problem? Might we be able to try discontinuing it for a while? Giving the physician accurate information about the effects of the medication on symptoms, and not looking for the medication to solve all the problems are things that we can do as non-medical professionals.
Then we mood stabilizers, lithium, Depakote, Psychotropic. These are all older medications, and through their therapeutic levels can be assessed to see if the medication is person well. And stabilizers address symptoms such as sleep disturbance, stress for long periods of time, irritability, and things of that nature. We have some antidepressants listed: Seroquel, Luvox, Paxil, Zoloft, Prozac are the ones that are commonly used for folks in our population. And it's good to collect data on this because this is another medication where people are on it for a long time, and we have no data to support if they are still experiencing symptoms associated with mood issues. It's just a list of symptoms that should be addressed or met if a person is on depressants. Which are seeing some of on that are assist people with sleep issues, sometimes address anxiety issues as well. Livan is another drug that people sometimes receive prior to medical appointments. Bennett, before bed, people sleep, and it's also a drug that should be used to address these and issues of nature. And again, this is the purpose of using the if people have issues with sleep, and it's very critical that if a person is not sleeping well, that teams collecting data for hours of 24-hour periods, because sometimes people are not sleeping at night, and that's because they're sleeping during the day, and they might not necessarily require a sleep aid. And then view of all of the side effects, issues, issues with agitation, aggression, all changes in their behavior are moods. And again, I piggyback off of what Dr. Rogers said, medication effects that sometimes mirror behavioral issues, which lead to being prescribed additional medication, and we're not doing a good job of tracking if people are experiencing effects of medication.
And notice that the medication's side effects can predispose someone to be less willing to do some things that are not pleasant for them. So they're already feeling uncomfortable. Asking them to do some work might make it might be more difficult. They might be more reactive to that. And so behavioral world, we call these motivating and abolishing operations. They affect the how reinforcing the consequences are, or the sensitivity to reinforcement. And we should be considering that as behavior analysts and behavior change professionals. Medication side effects might be making everyday life more difficult, and that'd be where we're finding some problems. So we need to do some adjustment in our switches and protocols if those medications are necessary. All right. Do we want to address a question here, Micah?
Yeah, I can't.
Okay.
I'm not sure under which age. I can't.
Okay. A couple of questions that we address. One of them is the presentation and handouts will be made available to you all following this, available next week, so you'll have them for referencing. The one is a question from someone asking, are these medications recommended for children? And the thing about medications right now is very little about what affects children over time. We know an awful lot of foster kids in the nation and in Missouri are on medications, children as young as 2. And here's the scary thing, we don't know how that affects their brain and their organs over time. Medications tested long-term for children, and so it's very scary. So say recommended is not a word we would use as behavioralists, and probably most medical professionals wouldn't say recommended. It's not like a vitamin or a healthy meal. It's not recommended. Okay. Any other questions? Okay, go.
Here's a review of significant effects: death, kidney failure, diabetes, increase in white blood count, Dyskinesia, and Akathesia. And tardive dyskinesia is when a person is not able to, they lose control of their muscles, so they have extra movement in their facial areas and sometimes in their extremities. And Akathesia is very similar to dyskinesia. And lots of tools that medical physicians can use to assess if people are experiencing these significant side effects. And if a person is, we want to get assessed by a medical physician so that so that a warning does not occur. An example of a psychotropic monitoring tool to assess if people are experiencing side effects associated with the medication, and so just lists the side effects, the basis for the person. So if the person is currently drooling, you might want to put a 0 and a line through it, and if they start experiencing some drooling, you would note. I have an example of actual tool, Teams 5. You'll get that next week with the presentation. And so you'll collect this information, team together, and share it with the primary care physician as well as the doctors who prescribe the medication. Okay, so studies are real examples. So Malcom is a 25-year-old who takes melatonin to aid with sleep issues. Is melatonin a psychotropic? So answer yes or no. Melatonin is a psychotropic medication. Earlier we described defined psychotropic medication as anything that affects mind, body, and behavior. And so because it's given to Malcom because he's having sleep issues, it's considered a psychotropic medication. And Dr. Rogers touched on this earlier, looking at how medication is used with folks who are being served by the Division of Developmental Disabilities. In 2015, there were 2,350 people who were prescribed 3 or more psychotropics for 60 days. There were 149 people who were on 2 or more antipsychotics for 60 days, and 425 people who were prescribed 5 or more antipsychotics for 60 or days. She talked briefly about the 23% of 1,300 children that were being served by Children's Division who were on at least 1 or more psychotropic medications, and there being enough on how that child long term.
I should mention is that there's no scientific literature that shows that multiple psychotropic medications in class have better results. In other words, no scientific literature, there's no data saying that 2 meds is better than 1. And that means if you have somebody on multiple meds for the same kind of problems, probably needs to be examined, and the people that are working with that person regularly and behavior analysts to provide data so that the doctors can make good decisions.
reviewing some of the expectations the Department of Mental Health has for contracted behavioral providers. Is we like for behavioral providers to make sure they are reading medications that folks being prescribed that are psychotropics, assessing if they are experiencing side effects and how those medications influence the person's behavior day to day. They should also be included in the behavior support plan with target behaviors associated with the medications. Behavioral contracted providers should also describe how data will be collected and communicated to the prescribing doctor as well as other teams. And once behavioral services are continued, there needs to be a plan in place so that it has a system make sure that there's oversight for those medications.
So we have a question. It's a really good one, and we're probably going to be talking about how to address this periodically throughout this presentation. The question is, if we notice that someone is on a great number of psychotropic medications, more than 7, so more than 7 is a great number, not just a great number. So more than 5 is a great number. Really, remember what I just said, there's no evidence that more than 2 has an effect in medicating for the same problem. So if you have concerns about the medications as a support person or an advocate for an individual, how would you do that appropriately? So we're not saying barge into the doctor's office and demand a change. We're saying doctors need data to make good decisions. So the best thing that we can do is speak to the medical professionals and say, this was prescribed for, because most often those medical professionals are taking over for somebody else who prescribed it and they may not even know what it was prescribed for. How can we evaluate this? Because this seems like a lot of medications. It has a health effect on the person, and what would help you to make better decisions. So really having a dialogue with those medical professionals to say, is this really the best course of treatment for this individual? What information can you give to me? What can I give to you to help evaluate this process? So an open, respectful dialogue that just says, I'm hearing this stuff about medications being not so good for you in multiple doses, so what can we do? That's what we're recommending, along with data collection and review.
Welcome to documents review. General Behavior Support Review Committee often has good insight and good input. So looking at psychotropic medication as a discriminant stimulus, so results from numerous studies have demonstrated that psychotropic medications can serve as a discriminant stimulant or impact a person's ability or impact the ability of other stimulants to serve as discriminant stimuli. 2 conditions must be in order for a medication to be a discriminant stimulant. The drug must produce effects that can be detected by the person, and the person must have a history of general reinforcement in the presence or absence of the medication.
Can you give them examples of discriminant stimulus? I'm on the spot and said, can you talk about what a discriminative stimulus is for the folks that aren't behavior analysts?
So when I reviewed this information, I thought about some of the kids who were in call hospital who are drug seeking, sometimes purposely had behavioral issues, so that they could get the injection and sleep through the day away or not have to interact with male physicians or therapists. Yes.
Okay. Okay. What?
Research will suggest that psychotropic medications can lead to this is of differing motivating operations. Thinking of
Okay. Just go ahead and talk.
the administration or removal of psychotropic medications can lead to physiological effects which may make other stimuli more or less reinforcing or punishing. Again, research was done in clinical and lab settings, but has ramifications for clinical practice. And, several have determined that psychotropic medications can serve as reinforcers for behaviors like and for control, and drugs also can serve as pushers. It's also interesting to note that additional research has suggested that some drugs may have little to do with the effects of drug. I'm sorry, is it just and effects of drug, and more on the possibility that the drug can become a conditioned reinforcer.
Okay. A lot of technical language, and we're going to talk a little bit about that, but I want to get to a question that Jamie had, and the question was back on our melatonin example. So technically, melatonin is affecting somebody's behavior. It's making them more likely to be able to sleep, and that's a drug affecting a behavior is considered psychotropic. So we're at that big definition of what are psychotropic meds. Psychotropic meds are medications that affect behavior or mind, so that melatonin would be considered a psychotropic, even though it's over the counter. Just Benadryl, even though it's over the counter, it's still a psychotropic medication if given for the purpose of relaxing a person or helping them sleep. If it's for allergies, then that's medical purpose. If for their behavior, that's psychotropic. So I hope it clarifies that question. We had another question that was from Megan. What organization did you contact for review of someone's multiple medications? So exactly for review of multiple medications. Multiple medications needs to be reviewed by the physician, and the physician needs to have good data and good decision from the people caring for the person and the person themselves, if they're able to provide good data to make those decisions of whether a medication is useful or run or not. National Behavior Support Review Committee for individuals served by the Division of Developmental Disabilities can help the team to determine other strategies or even how to measure the effects of psychotropic medications. They don't give drugs consulting, because they're not physicians, they're behavior analysts. They can talk to you about how to measure the effects of medications or the effects, and where strategies might be more appropriate than trying to medicate behavior. So the Regional Behavior Support Review Committee is headed by the area behavior analysts. There are 3 area behavior analysts in the state. Atlanta is the one for the eastern regions. We have Lucas Evans for the central regions and Rita Cooper for the western regions. And they're based in regional offices and can be contacted there to talk about how to get somebody on the Regional Behavior Support Review Committee consultation list to be reviewed for measurement recommendations and for strategy recommendations. They do not review medications per se because they're not medical professionals. Have multiple psychotropic medications for longer periods. It impact brain chemistry, and if yes, what steps to medications or stop them? So, as the only way that those medications work is by impacting chemistry, because they're chemicals. And the long-term effects of psychotropic medications, or any medications for that matter, are pretty much unknown for children, but especially for psychotropic medications, because children that have been prescribed medications for a long period of time are just now growing up, and there hasn't been any good clinical trial on the effects of medications long-term for children. Just come out for Ritalin and those kinds of drugs. And so there's an area of concern because we know that it's impacting their major organs and it's impacting their brain. For adults, long-term use of psychotropic medications lowers the mortality age and causes some continued health problems. So if it's true for adults, it must be true for children, probably. But we don't know that. There's just no good scientific evidence yet about that, and so that's what the concern is. In terms of evaluating it, that's what this presentation is about, is to make you aware of what kinds of things you might be looking for, to try to give some objective data to the medical professionals, to understand that not all problems can be solved by medications, and some of them have to have environmental or behavioral strategies that are used, so that we don't come to the doctors demanding for a problem that really is a behavioral or environmental issue. So really kind of raising all of our awareness around that and helping to advocate for good care from the medical professionals. Okay, one more thing. Remember at the beginning when I said that there was going to be technical language in here, and apologize for that for folks that are not behavior analysts. We will be following up with several future presentations, and so one of them can be, if this is a debate, one of them can be for non-behavioral professionals, so that there's less technical language. We're really appreciative of the interest and grateful to have your attention, and we'll be trying to explain technical language a bit as we move along. And there's a wide variety of participants, and so not every topic is going to hit your need, but hopefully you'll still get something out of the presentation.
Okay, and so question, what 2 conditions must be met for a drug to be established as a discriminative stimulus? Okay. The answer is A. The patient must produce an effect that can be detected by the person, and the person must have a history of differential reinforcement in the presence or absence of the medication.
So, a question from Jamie: will any over-the-counter medication be used as a psychotropic medication to affect the behavior or the mind? Need to be noted in the ISP, and would that need to be reviewed by the Human Rights Committee? So, yes, if you're using a medication to affect the behavior of an individual, it needs to be noted in the ISP, and it would be great if the ISP said what symptom it's supposed to be addressing and what the baseline was and how do we know if it's working. And what we're trying to move this system towards is understanding that we need to know the baseline and how we know it's going to work. And so if medication is for pacing around the room, agitation is for this individual. But if you say it's pacing around the room, then I can start measuring how long they're pacing every day and seeing if the medication has an effect on them. So yeah, it needs to be noted in the ISP, and just whatever rules are you're following for psychotropic medications, you should follow for over-the-counter psychotropic medications also.
And also hoping that teams will come together and look at the purpose of the medication. So if a person is taking melatonin because they are not sleeping, has the team looked at medical issues? Experiencing some psychiatric issues that have not been addressed. So just having some good discussion as to why the person is experiencing whatever behavior that they're experiencing. This slide just basically talks about how psychotropic medications can affect a person. It can a person's motivation to access reinforcement. Is a psychotic, and some of the side effects are weakness and for fluids. It's less likely that that person is going to want to bed and engage in activities or with people. So that's an example. Medication can reduce the value of reinforcement or something more reinforcing. For instance, if taking Zyprexa and the side effects is increased hunger and the person eating chocolates for completing tasks, it's more that person will work harder because they have a stronger desire to eat and for sweets. Psychotropic medication can affect a person's ability to focus and retain information, which also it can be struggling for people who are caring for that person on a day-to-day basis. They may not understand why this person is missing steps when they are putting on their clothes or brushing their teeth. Affect medical status. We saw one of the slides that one of the more serious side effects of medicine is diabetes, which can play a role in a person's their mood status, and these things will affect the person and their individual support plan as well as their behavior support plan. Okay. Here is a real life situation. I worked with a person who was a addict. She went and saw the endocrinologist, and endocrinologist consulted with her primary care physician, and they decided that Seroquel was having on her status diabetes that was causing her levels to rise. So they removed the Seroquel and put her on a heart healthy with no concentrated sugars, and they started a Abilify. So after that medication was, after Seroquel was continued, new behaviors emerged. She was confused. She struggled to complete her daily routine with going to work, and she became verbally and physically aggressive. And what was going on with her was she was experiencing associated with Abilify, and so the team got together, collected data. It took about 3 months to have enough information for the primary care doctor, the psychiatrist, and the endocrinologist, and they and kept her on the heart. I don't know why I'm struggling, and discontinued the Abilify and started the Seroquel, and she returned to her baseline, which was workday and being a very, very pleasant person that didn't display verbal aggression or physical aggression. We have another polling question.
What?
For our contracted.
This is going to be for this question. What we'd like you to do is write in a word or two in the question and answer box on what you think the role of the behavioral provider is in relation to all of these things: target behaviors, data, behavior support plan, the treatment team, for the prescribing physician, and for able to keep going in the behavior plan strategies and medication communication. So what should the behavioral provider be? And what we're hoping is that all of you are more aware of what the behavioral provider should be doing, so that you can look for it and try to facilitate it and understand when certain things are asked of you. So even though not a behavioral provider, if you could give us a 3 to 5 words answer in the question and answer box on what is the role of the behavioral provider for these issues. Put it in mute. I'm going to see if I can find out.
Great answers. So the role of the contracted behavioral provider is to define behaviors so that they are measurable. And lots of people wrote that in. Data to be collected on target behaviors and medication, and one noted to monitor and share with treating physicians. So that was great. Medication included in the behavior support plan, and the contract provider should be viewing the behavior support plan that includes medicine with the treatment team, as well as the data. The team of contracted behavior provider, because the provider is not long-term service, developing a system to identify who is going to, what position to consistently work with the prescribing physician. Data should be shared with the prescribing physician as well as the treatment team, which includes the guardian and other clinicians, and how that system will operate once the provider fades out. That should be noted in the person's ISP. So again, I had some great answers, and a lot of people said that targets should be defined well, data should be collected, sometimes is to aid. So all were great answers. For behavioral providers, the Division of Developmental Disabilities, the waiver states that there is evidence that when someone is prescribed any kind of medication, that the medication is doing what it's prescribed to do. And this is just a reminder that we need to have lots of discussions when people are taking medication, as well as medication, to make sure that it is treating what it's prescribed to treat. And our behavioral providers, our code of ethics state that we should be assessing any form of treatment that the person is and will affect our behavior plan, and as discussed through this presentation, medication effect. So assessing and having discussion and collecting data, and work teams as well as prescribing physicians is in the wheelhouse. So some of the patients for improving best practice, and that's basically what do we do now that you receive this information. We should practice model for psychotropic medication use. About the Regional Behavior Support Review Committee, it's open to supporting teams where we have people who are on 4 or more psychotropic medications. Rogers did a good job of explaining we will not necessarily assess medication, but we'll look at the behaviors that are associated with the medication and talk about their strategies that may be beneficial. Research shows that ADE, along with medication that is medication, leads to behavioral change. Team also use, and you'll get this, the psychotropic medication check list twice a year or when there are medication changes. To make sure that they are collecting data and monitoring the side effects. Presentation, I showed you guys an example of a tool that you can use to monitor side effects. You'll also get a copy of that. Family, agents, any a person that's prescribed psychotropic medication can use the feedback and exchange form at appointments with doctors who prescribe psychotropic medications, because all the time it's not always psychiatrists. And you guys can do what you did today, which was continue to look for opportunities to learn about psychotropic medications. And so talk a little bit about the best practice model for psychotropic medication.
Okay. And before I do that, I'm going to look at our question and answer box and respond to some questions. One by Jenny is, if research has shown that ABA is effective, why can't kids who aren't on the autism spectrum have access to it? Here's the good news: they can. Now, who pays for it is the question of the day. And if you're looking for private insurance to pay for it, the insurance mandate only requires insurance companies to cover it for kids with autism or kids on the spectrum. Change, you make noise and advocate for it. In the Medicaid world, if the child needs potential needs behavior therapy or behavioral services, you can ask for an early I always get these letters wrong, EPSDT evaluation by the physician, and they can recommend it. But if they're child's developmental disabilities or intellectual disabilities, and they're on Medicaid waiver, they can have access to behavioral services even if they do not have an autism diagnosis. So let me repeat that. If the child is on a Medicaid waiver, they can have access to behavioral services even if they do not have a autism diagnosis. So that's, now the problem might be sufficient provider access or capacity. We're working on that, but it's not a requirement that a child have ASD to get services. The problem is trying to figure out how to get it funded. So that's something to look at. We've got Meg asking for the presentation, so I'll repeat again that the presentation will be sent to you next week as we get it uploaded into our system, and so that will be available to you, as will some of the forms that Melantha will be talking about in a few minutes. The division email blast is how it will go out. If so are on the division email blast, you will get this this presentation. Or if you signed up for it too, right?
Right. If you haven't signed up for the division email blast, if you will go to the division's homepage, so go to dmh.mo.gov, click on Division of Developmental Disabilities. To that landing page, there will be a yellow rectangle box on the right-hand side that says, I think it says sign up for division email or get division email, something like that. It's not hard to find. That you can sign up to receive our division email blast. And so anytime we hold a webinar, follow that within a reasonable amount of days, we will send out an email blast to everyone that's on our distribution list there, and will receive the links to the recording. They will receive the link to the presentation. If there are any additional documents that go along with that webinar. Also, you can go on our division homepage. The last bullet item on the right side of the screen says webinars. You click on that, you can see the upcoming webinars. There's also the option to click on previous webinars. You can scroll through that, and that's the spot where you'll find the recordings and presentation, and those are listed in chronological order.
And so can gain access to those by going on that website and looking for it. And so I see you had a response that Medicaid or regional center funding do not cover it, and I disagree with you, but if they are on Medicaid waiver, not straight Medicaid, Medicaid waiver, a child who has the need can request behavioral services, and it will be funded. Whether a provider immediately available to provide service may be a problem, but the Medicaid waiver will fund behavioral services for children who have a need identified for it. So, all right, now Melinda is going to talk about the best practices model for psychotropic medications, and I'm going to give you a little background on where that model came from. So a number of years ago, a group of us did a big research on were psychiatrists recommending, what was the field recommending, that psychiatrists or medical professionals do before or they psychotropic medications. And so this came from an international psychiatrist, and this medication prescription model is followed pretty closely in some progressive countries like Great Britain, Netherlands, Australia, those kinds of places. And this is what the psychiatric community, as well as the behavioral community who knows about medications, recommends for all of us who are involved with individuals who may be prescribed psychotropic medications.
So what we want to do is make sure that we are ruling out all medical issues. Some of you guys may not be aware that there are a lot of medical issues that mirror psychiatric or behavioral issues. For example, a person who is dehydrated can be bad, as well as confused. A person that has an iron deficiency can also have issues with mood, concentration, and some measures, also behavioral episodes. So we just have to do a job of making sure that medical issues have been ruled out. You also get a copy of a form that lists medical conditions that mirror behavioral issues. Once medical issues have been ruled, it's good to bring in contracted behavioral providers to do functional behavioral assessment. And what the assessment does is part of the process involves interviewing people who know the person well, collecting data. The person has historical records, reviewing those historical records, looking at the medication, and that contracted behavioral provider will then explain what's happening in the person's environment that is leading to the person displaying those target behaviors, and the functional behavior assessment will identify some broad strategies that will later be implemented in the person's behavior support plan. Once that the medical issues have been ruled out, the FDA has the provider in there to provide those behavioral interventions. The medication is still considered to be something to address the person's needs. Then it's important to try one psychotropic medication at a time and the effects of those of that medication. So that's a good time to use that that will allow you to monitor the side effects of the medication, as well as collecting data to see if it's being prescribed Zyprexa to address aggression. There's actually a reduction in the aggression, or if a person is being prescribed trazodone because they're having issues with sleep, are they getting 7 or more hours of sleep, 24-hour period, and sharing that information with the team and treating physician. And the example of a medication that should be included in a person's behavior support plan, ASP. The first column lists the medication that the person is on, the psychiatric issue that the medication is minimizing the symptoms, the main range, and then the behavior in which the team and that person should see a reduction in. So they want to see in a person's behavior support plan or ISP. For that as well. That's this slide. Talk briefly about one of the things that what's next step. One of the things that the treatment team can do, and they can medication information exchange and feedback form when they are talking to physician, and so and complete the form. Our first section is just basically making sure you have the correct date and the person's there. And then the second below that is just demographic information. There is instructions to out of that, and then looking at the purpose of the visit. And so you can identify the purpose of the visit. So if you one of the questions was, what do we do when a person is on 7 or more medications? So you for the visit could be that you're concerned that this person is on 7 or more medications and not seeing evidence that the medication is working, or you're concerned that that person is going to have medical issues. So that's an example of the reason for the visit. Another example of the visit could be just in and out of the hospital a lot, and you're not sure what a psychiatric crisis actually looks like, so you want the doctor to kind of help you define it and what steps need to be taken if a person is experiencing a psychiatric crisis. Another, if you want some dialogue with the psychiatrist about the side effects of the medication. So you can have various reasons for the and you want to make sure that you bring in the person's most recent list of medications, and it's just not the psychotropics. You want to make sure the treating or prescribing a psychiatrist has a list of all of the other medications that the person takes, as well as labs, consideration for the doctor to have. You want to be able to describe what symptoms the person is displaying and your concerns about those symptoms, and how those symptoms are occurring. You just simply check these boxes if the person is having the symptoms twice or every 2 hours. You want to make sure that you're sharing that with the prescribing doctor. And then you look at how severe the problem is, and severe has a range. Sometimes it really has little to no impact on a person's life, and then it can be on the other end of the spectrum in which the person is coming in lots of contact with law enforcement and hospital mail. It's going to be critical to look at things that are happening in the person's environment, or if they've had any major life changes, such as sleeping, if they are if they are experiencing changes in their eating pattern, whether their intake is increased or decreased. The same thing with weight and trial regimen as well. And then we're going to ask the prescribing physician to give him some information. And the physician should be able to tell you that they're prescribing Zyprexa because this person has a diagnosis of bipolar, and we want a decrease in physical. And he should also tell you the time of day that this person should be taking the medication, as well as the range. And you can things that you can ask them. It's a good question. When we're setting the medication, should this does this medication do a better job if the person takes it in the morning, or the night? If they take it in the morning, will it make that person sleepy today, which again will affect how the person interacts with their environment? What is receptive medication? What are the steps that need to be taken? Reviewing the common side effects, and what is the point the steps that need to be taken that the person is experiencing dehydration because they're taking Abilify. What should the team do? Does that mean we need to back and get a new medication, or should we increase the person's intake? So next discussion with the treating physician.
Division of Disabilities care providers, that stuff, you're going to want to have that stuff documented so you can put it in the record and you can refer to it and include it in your implementation plans or follow-up plans from the physician's appointment. So you do need to have that documented and use a form like this or this form to do that, even if you have to write it down and all the physician does is sign it. It can be very helpful for you to what you're supposed to do, and if anything weird happens, you have that documented.
And then the remaining sheet is just a data tool that you can share information with the prescribing physician. You're going to, on this form, date, the person's name, the month in which you are collecting data. You're going to number of hours, that the person sleeps, and this is all good because it look. Again, I talked earlier about there are times when people are receiving sleep aids because they're sleeping at night, but they're sleeping during the day. So this covers the entire thing. And then, so you complete this form. You'll any other additional concerns you can note at the bottom to discuss at the next appointment. And so, as highlighted earlier, when the email blast goes out, you guys will receive digital documents. You will receive this feedback and exchange form, the tool that will allow you to monitor side effects, a reform for the Regional Behavior Support Review Committee, and PowerPoint.
Okay. If there are any other questions that we can answer, you can write them in to the Q box, and I'll answer some of the questions that have already been written in. So, does the length of time a client is on a psychotropic make a difference in terms of the effects if drug is discontinued? Well, okay, so that's a multi-packed question. Depends on the side effect. So if it's tardive dyskinesia, once someone develops tardive dyskinesia, will have tardive dyskinesia for the rest of their life. That's why I want to be very, very careful with psychotropic medications and make sure that we're not over-medicating someone, because that makes it more likely that they will develop these tardive dyskinesia symptoms, which will then be with them for the rest of their life. But some side effects will go away when the medication is discontinued and it's out of their system. Every medication has what's called a half-life in the person's system, and it means how long is it in the system before 50% of it is of its effects and the medication is out of their system. And so I can't tell you each of those things, because that's really what a pharmacist or chemist would tell you. But those symptoms will dissipate over time. It takes about 2 to 6 weeks for someone coming off a medication for it to be completely cleared from their system, again, depending on that medication's half-life. And so those side effects might go away from that period of time. Some medications, some of the side effects dissipate as the person is on that medication. So, for example, if you take Seroquel, which is an antidepressant, the first 2 weeks you often experience dizziness, nausea, lethargy, but as your system accommodates to that medication, those kinds of side effects go away. So you have to be aware of those kinds of side effects. So that's a multi-packed question. Like I said, I tried to answer all the ways that you might be meaning to answer that question. Another question that we have is if medications that are prescribed for muscle spasm, an accident, or for individuals with cerebral palsy are considered psychotropic. So let's think about why those medications have been prescribed. They might affect a person's behavior, and they might not have been prescribed to do that. So that's something to keep in mind. But if they're for muscle spasms, that's a medical reason and not a behavioral or psychiatric reason, and so we wouldn't, unless it was affecting their behavior, consider it a psychotropic medication. We had another question that was asking about if someone has experienced trauma, would it be a good idea to get trauma-informed care or some kind of trauma treatment? Always a good idea to treat anything that's a problem. So, and we should be aware of the effects of trauma on our population, because percent of the folks in care have experienced some kind of traumatic event. So, yeah, it's a good idea to have that kind of treatment. I'm waiting to see if there's any other questions that I can answer for you all. The presentation formally is finished, and we're just here to answer questions. Also, if you could give us some suggestions of things that you would like to learn more about, we'll try to develop those kinds of trainings around psychotropic medications, or get some experts in here that can answer those kinds of, provide that kind of information for you. So as we're wrapping up, I think we'll probably, unless there's another question that I can answer, put ourselves on mute and leave the line open for you all to write in suggestions. we have testing, and if that would help determine which psychotropics might best serve an individual. That's a very young area of medicine right now. Many psychiatrists don't know how to read the genetic report, the genetic testing report. Lots of medications haven't been tested out and linked back to genetics. So it's a young field. There's some indications of it being useful to determine medications that a person might be sensitive to or might not be sensitive to, but a very young field. So we're kind of looking for that to develop more to be broadly useful.